We are working in Chapter 8 this week, Medical Staff Organization and Physician Liability. Learning objectives are listed here on the screen, on the PowerPoint, and also on page 137. So, medical staff organization. This chapter is going to provide an overview of the organization, credentialing process, review of cases for legal risks, principles of medical ethics. The medical malpractice cases presented in this chapter are which tend to be the most vulnerable with healthcare law. All right, so a medical staff, when it comes to committees, medical staff organization is full of committees. There has to be. You have to break down all these responsibility into subcategories, and they break them down into committees. So the executive committee, this oversees the activity of the medical staff. Committee members typically include a chair, chief executive officer, nursing director. Responsibilities include governing the process of medical staff structure, credentialing, delineation of clinical privileges, peer review, disciplinary actions, etc. I promise I'm not going to read every one of these to you, but there's a lot that this one does. There's a bylaws committee. You can read all about that one. Blood and transfusion committee that has to do with blood orders and if there's ever a larger reaction such as that. Credentialing committee, this is the one who oversees the application of medical staff, and they have to really do some thorough background checks when it comes to physicians applying. The chapter gets more into that in just a few minutes. Infection control, obviously that committee would oversee infection control. A medical procedure or medical records committee, that they're the ones that monitor the online records, healthcare charting systems, documentation, etc. They monitor for accuracy and make sure the records reflect condition and progress of the patient. The pharmacy and therapeutics committee, yes, there is actually a pharmacy committee who oversees the ordering of drugs and making sure we have enough drugs in stock, etc. Make sure the right medicines are given at the right time, etc. Tissue, yes, a tissue committee, because somebody has to be in charge of surgical procedures and when tissue harvesting is justified, when it's ordered, make sure it goes to the right patient, make sure it matches orders, procedures, left side versus right side, all that good stuff comes into play. Utilization committee, that is a real thing. You can read about that. There's a couple of slides on that. Okay, so medical director. Medical director serves as liaison between the medical staff and the organization's governing body and management. In Texas in 1981, there was a medical director indicted, and he tried to get out of it, I guess, and his defense was that he only signs papers. He doesn't have the responsibility of maintaining an organization, and he lost that case because that is not true. As a medical director, you do have a lot of responsibilities on your shoulders, whether you are an active leader or not. You still take that title, and along with that title came the responsibilities. You can read about that on page 139. Medical staff privileges. So medical staff privileges are restricted to those professionals who fulfill the requirements as described in the organization's medical staff bylaws. So obviously, as a nurse, I could not apply to work as a doctor at the local hospital, but it's up to the privileging and credentialing process to confirm that. There must be a thorough investigation of an applicant's qualifications and ability to perform specific privileges requested. And as you read through the book, you're going to see all sorts of not case studies, but examples of medical law, healthcare law. And there are a few that have to do where someone was an imposter, maybe not necessarily in this book, but they pretend to be something that they're not, or, say they have a licensing or a certificate to do certain things when they really did not. And that responsibility does fall on the governing body of medical staff because it's their ultimate responsibility to confirm licensing, credentialing, etc. Page 139, it talks about the application, the physical and mental status review, certificate of insurance, licensure, references, etc. I'm going to keep going through the let me back up one slide. This National Practitioner Data Bank. So this was created in Congress as a repository for information, and the primary purpose is facilitating a comprehensive review of physicians and other healthcare practitioners. So this is where we would find information if a doctor or practitioner has written too many narcotic prescriptions, or they operated on the wrong limb, or they have any type of charges against them, any pending information. All that's going to be in this data bank that Congress created. I think I mentioned references as far as being the application process. Yes, I did. I've got that highlighted in my book. Governing body's responsibility, that is spelled wrong on the PowerPoint, but that's okay. But it's the ultimate responsibility for granting medical staff privileges of what it's referring to as the medical staff organization. The governing body has the responsibility. Okay, this slide, limitations on requested privileges. So that's in the book on page 140, and what that's referring to is not all doctors have the same privileges. So one ER physician may have privileges to treat traumas but not treat OBGYN, because that's a whole different specialty. You have to have certain, privileges to do. Maybe in a hospital or a doctor's office, you did A, B, and C because you had the privileges, but when you change healthcare facilities, you may only get privileges for A and C. So you cannot perform step B, that's just my example, because you don't have those privileges. Misrepresentation of credentialing, that's a big no-no. I'm going to keep going. I'm going to go fast as I can with it because there's so many slides, and this is a very large chapter as far as it's not a ton of pages, but it's a lot of information. So disruptive physicians, yes, this is a thing, a real thing. And hold that thought for just a minute. Let me go back to my book and make sure I talked about that. One thing I want to go back to, I'm going to flip this slide back real quick and see if it mentioned it. It did. So medical staff privileges, part 3, this slide. Physician supervision and monitoring. This is a real thing. A little more challenging in doctor's offices, private suites, if you will, where there's, several different practices in one. But in a hospital system, the way they do this is peer review. They get feedback from nurses, fellow surgeons, fellow doctors, fellow dentists, etc. But that does happen, and stuff, anything that you're not happy with can be reported to the medical board. That's anybody. Practicing outside the field of competence, I sort of hinted at that with the examples of working one place with privileges and then working the other. But the case that they give in the book is regarding the plastic surgeon. So the burn patient came into the ER, the doctor just treated him as best as, I'm quoting here, as he could, but a certified plastic surgeon was needed, and the certified plastic surgeon should have had burn experience, and this ER doctor did not. So at the bottom of page 141, the middle of the page over to the right column, it talks about that. So definitely don't want to misrepresent any credentials. I talked about that. Okay, let me go back to this slide now. All right, disruptive healthcare workers, it is a real thing. I mean, all the way from yelling to flipping operating room trays with sterile instruments to screaming and demanding everybody to stop in the trauma room because it was just utter chaos. Yelling at patients when patients yell at them first, or maybe it was unprovoked. I've seen a lot. It's real. It does happen. Yes, it's rare. I can say it's rare, but it does happen. So read that paragraph, disruptive physicians. And there are practices or rules in place at healthcare facilities. And I would, challenge you to look into that a little bit further regarding civility or incivility or disruptive healthcare workers. Okay. Oh, look, disruptive physicians rage in the OR. Yeah, it really does happen. Pose a significant threat to patient safety, even other healthcare worker safety when trays go flying, or even if the anesthesiologist and the surgeon are maybe arguing over which leg we're actually supposed to operate on. Hopefully it would never get to that point, because prior to going into the OR, you're supposed to do so many checks. But yes, healthcare workers can lose their temper. All right, so page 142. I want you to, I promise I'm not going to read this to you. I'm going to highlight some of my biggest takeaways, but from page 142 all the way over to 154, read it, review it. I want you to just expose yourself to the potential medical errors. Like I said, I'm not going to read it to you. Misdiagnosis. I will highlight this one. This is the most frequent malpractice issue, is misdiagnosis. And there's tons of different reasons that can surround that. All right, let me keep flipping here. Discharge and follow-up is very important, yes. All right, so section on infections. Let me get my PowerPoint caught up. Common medical errors, yes. Failure to conduct a timely assessment, especially when hospitals or office buildings are just busy. Failure to conduct a thorough assessment, that also has to do with rushing. And sometimes it can even have something to do with your patient doesn't speak the same language as you, there's confusion, but that should never stop you. That there's always an interpretation line that's actually free. And with the invention of internet, we can actually, I think Google translates for free. So we should never use that as a reason not to conduct a thorough assessment. And then inadequate assessment of an unconscious patient. That can be intentional and unintentional when someone's unconscious. Okay, diagnosis. Yeah, I am not going to read these all to you. Common medical errors for diagnosis, failure to order tests, etc. Delaying conveying imaging results. That does happen sometimes. Radiology gets backed up, and then a doctor may move on to a different patient and forget to go back and look. There are systems in place, though. If it is a severe result from imaging, radiology, lab, if you send off labs and maybe you moved on to the next patient, you forgot you ordered this critical lab, the lab actually, as for checks and balances purposes, the lab will call to give those findings if they're severe enough. And same thing, like I said, with radiology. All right, patient allergy communication breakdown. Yes, this is definitely part of medical errors. I've even, these are good ones too. I have even been in a patient's room where a doctor walked in and said, "Hello, Mr. Brown." And the patient's name was definitely not Mr. Brown, but the patient said, "Well, hello, doctor." Like the patient didn't correct him. Some generations do not believe in correcting a doctor. You know, we talked about the history of medicine and how the evolution of physicians' practice has evolved, and some generations, our older generations, even my own father, would not question a doctor. They would just go with it. And it wasn't until I spoke up and, you know, for example, I said, "Mr. Jones, that you need to tell him you're not Mr. Brown." You know, just you speak up for yourself, and that man would have never done that. They just kind of go with it, and that's how we accidentally have the wrong patient operated on, the wrong side, that sort of thing. Okay, so let me stop talking about that. All right, no, this is still talking about med errors. So treatment, yes, this can be, there's two schools of thought. Oh, I highlighted that. Hang on, let me go back to that page. Oh, where is it? I'm not going to be able to find it fast enough. But make sure you read that in the book, the two schools of thought, because it is, I can see both sides. All right. Common medical errors, we're still talking about that. Let me flip through these. All of this is in your book, discharge and follow-up. Yes, you have to follow up. And the discharge orders have got to be explicit, and you have to confirm that your patient understands before you send them home. All right, here we are, infections. So nosocomial infections are ones that are hospital acquired, and it is the highest death, unnecessary death, and it's related to poor practices. Poor hand hygiene, not cleaning surfaces, is how we get infections. Dentistry. So my sister just happens to be a dental hygienist, and I asked her prior to recording this video, what is the likelihood, or what is the prevalence here? And she shared a case with me. If I think about it, I'll share the link with you. But in 2017, a judge in Colorado awarded a patient $2 million, $2 million, because a crown was done incorrectly. They ended up with infection, endocarditis, etc. That is the largest ever malpractice payout for dentistry. Okay, so this is just examples of what can happen. Obstetrics, this is a high risk malpractice arena for so many reasons. One, you have two patients most of the time. You have a female, obviously, mother and a baby, female with a newborn baby. All sorts of things can go wrong. You can read about that on page 148. Psychiatry is another one that is very, very risky as far as malpractice, just because of so many things. Issues regarding commitment for mental wellness, untimely discharge, of course, if you discharge somebody too early and they still need mental care, and there's just a lot of risk with psychiatry. Abandonment is when the relationship between a physician and a patient ceases, whether it is agreed upon or not. There's certain procedures, if you will, to professionally and what's the word I'm looking for? Permanently, accurately stop the physician-patient relationship, and you can read about that on page 160. You can't just abandon a patient. You're not supposed to anyway. Personalized treatment at the top of the slide is the number one way to avoid malpractice. You have to make the care personalized. What does this patient need? And obviously there's rules to follow, but you want to make sure you've done everything for each patient individually. Do not overextend your practice. Limit telephone orders. The reason this is in here, and I'm sure it explains this too in the book, but things can be misinterpreted when they're heard on the phone or heard, via your ears. So if we were all in a classroom and I had you all line up and told the first person the moon is full, well, by the time it got to the third or the fourth person, what's repeated may not even have anything to do with the moon. That's just our ears and our brain do not always hear things correctly. And then when we go to repeat them, they're not accurate. All right, what else can I tell you? Medical ethics. The Code of Medical Ethics is on page 161. That's serious business. When we as healthcare professionals take our oaths, when we graduate from school, and review questions. Okay, I don't have time for review questions. Physician-patient relationships on page 162. Read that. And that's it. I'm going to stop talking. I didn't mean to dismiss these review questions. You can certainly review them on your own. Read the chapter and let me know if you have any questions.